morning, good morning. I feel like I'm preaching to the church here. So if you can't hear me or you can't see the slides, please move forward. But I will caution you ahead of time. I was really going to stand down here, but I can't see everybody, so I'm going to stand up here. And I don't want you to stare at my dorky shoes. And they're held together with rubber bands, so I will admit that to you right now. And they're red rubber bands. I'm recovering from a stress fracture of a toe. Has anybody ever had toe problems before? They are the most undesirable kind of injury you could possibly have. So again, now everybody's going to look. Okay, yeah, they're really dorky shoes, and they fit the toes, they don't fit the feet, so that's why the rubber bands are there. Anyway, that was my solution. But welcome, and I understand that it's been a wonderful start to a wonderful conference. So what we're going to do is a very informal kind of conversation about who's going to care for us. And I hope that there is some excitement in the room in terms of somebody better be out there, because as we all age, we're all going to need some kind of help. And that's really the theme today. All of us are going to need some assistance at some point in time. We also want to make sure that we stay as independent as possible, and hopefully that's the wellness side of things. But eventually, we're all going to need some help. And I will tell you right now, it's going to cost us something. And we're going to talk a little bit about this healthcare reform. We're not going to get into healthcare 605. We're going to go into healthcare reform 101. And we're going to keep it real basic, but we're going to talk about that. But I think the first thing we want to do, though, because I know we're between now and that chocolate cake and that lemon cake that I saw out there on the plates. Did you see that? The icing is about that thick, so enjoy it. But anyway, we're going to get to the heart of talking about things here. But a question to you is, when you think about old, when you think about aging, when you think about elderly, what's the first kind of thing that comes to your mind? The first thing. Pardon? You're going to have to speak up. Ma and Pa kettle. That would not be on my top of 100 list, but that's fine. First thing you think of, aging, old. Parents?
Will I be able to take care of myself?
Okay. Anything else? Money from the financial side? Yeah, you're being a realistic kind of person. Nursing homes. Health. Think about what we've just heard said. And we're going to talk a little bit about this. Most of it was in a negative or not a positive connotation. Oh my goodness, dementia and Alzheimer's, you talk about not on the positive side. And we just had a conference speaker talking about the positive side, so let's keep positive. But we're going to talk a little bit about those negative perceptions, and we're going to switch it to a positive perception too, because every single one of you has a concern about this aging process. And talk about how we define old. It can be in a variety of ways, because is it how old I feel? Some of the patients we see at Deaconess are 50 years old, and you know what they look like? They look like their bodies are 80 years old plus. They've misused their bodies. Again, we're not here to preach. Again, I told you this was the church, but we're not here to preach. It's all about that feeling. Some people judge how old they are if they carry a Social Security card. We probably should say that as a Medicare card. When you carry your Medicare card, and if you're 65 years of age, you know you have to register at least 3 months in advance or 3 months post the age of 65. Is that when you feel old? Is that when you are old according to the American terms? A lot of this is in the head. How old do I feel? Do I feel old today? Do I feel young today? Am I over age 50? Does that make me feel old? Again, we're going to talk a little bit about this concept of feeling old. But what I'd like to do now is show you some pictures. And I want you to shout out, and hopefully we won't have a great big ruckus here. What's the first thought that comes to your mind when you see these pictures? Fun, joy, beach, free, healthy. I heard healthy. Okay. Happy.
Memories.
This is audience participation time. useful? See, it's all in your mind. How do I perceive this? Let's do a couple others here. A very positive connotation. What does this bring to mind? Good for her. How many of us are going to be doing this? And it'll probably be the e-cigarettes at some point in time that will be allowed in the nursing homes, right? Okay. What does this bring to mind? Old? Old in a positive way or old in a negative way? Okay. Last one.
Family, happiness.
You feel positive vibes? Again, it's that positive energy that is going to make a big difference in terms of, do we feel old? Do we act old? So, the goals for today, and they're going to be very brief because this is going to be interactive and we're going to learn together. I'm going to learn as much from you as you're going to hopefully learn from me. We're going to talk about some perceptions. We're going to talk about who's out there to take care of us. And then we're going to say, who is really going to take care of us? And we're going to try to get that question answered. Again, there are no standard scientific answers to any of these questions here. But this is the question posed, I think, by lots of family members. Who will take care of me? Will my family be there to take care of me? If you became ill today, regardless of your age, just by a show of hands, how many of you have family members that would come to your rescue to say, I'm here to help you? If they say there's a qualifier there. I would not be able to raise my hand. I don't have family here. And I don't think my brother and sister would take time out of their schedule to help me. So I've already made other arrangements. But this is the question posed by lots of people, even our age. Who is going to take care of me? So that's the theme of today's conversation. I want to tell you a little story because when we talked about the elderly, we talked about health, we talked about some positive things, we also talked about some negative things. I want to bring home to you a real-life story about our health system at work in helping an elderly woman. This woman is in her 90s. She's a very dear friend. And she called me to her house, probably about 3 months ago and said, Linda, I have a problem with my foot. And I don't know if you can clearly see, but there is some puffiness there, and I called it pitting edema. But it was very confined to the foot. It was almost in a triangle. And I asked her if she had had something traumatic happen to her foot. And she said that she had had a hammer toe repaired at a doctor's office. And you can barely see a little tiny bandage down on one of her toes down there. So I said, I think maybe you might have an infection going on. So I took these pictures, I sent these pictures to her family doctor, and I made sure that he could see that, you see the little raised triangle? What I call a triangle? And it was, the skin was intact, and then I took a picture to make sure that the doctor could see the difference between the 2 feet, and there was an obvious difference, and I hope that you can see that with the pictures here. His comment was, well, you've had surgery about 5, 6, 7 years ago for a femoral popliteal bypass so that she could get circulation to her leg. I think that's just what it's all about. But to be on the safe side, let's give you some antibiotics because there might be a little infection going on. It's so localized. Went on, and this was about 2 weeks later. She called me and said, Linda, it's not getting any better. In fact, it looks worse. So I went over to her house, and I am no doctor. I'm just a good friend. And I said, oh my goodness, what's going on here? She had dropped a box of stationery, if you can believe this, on her foot, and that's what caused this scabbing. And I said, there is something else going on here because that little tiny triangle has now escalated, and we could not get the attention of her doctor. And I believe in our medical system. Believe me, I believe in it. But we just could not get the attention. So I took her to the doctor's office, and ran some tests. A Doppler study was done to test the blood flow of the leg. That all came back normal. But there was still something going on with this leg, and I'll show you a picture or two. Let me go back one. See how different it was? We could not get the attention of medical help to help solve this. And then finally, a physician said, you're just going to have to live with this. She is over 90 years old. She drives. She's very independent. She has no family here. She lives by herself, sharp as a tack, and this was slowing her down. She could not go out to lunch. Her foot was so painful. Regardless of her age, she needed attention. She could not get the attention, and I sort of believe it was because of her age. She'll just have to learn to live with it. How many of us would put up with this? Lo and behold, a retired surgeon came to her rescue, retired surgeon, and said, I think you've got some lymphedema here. Let's see if what we can do to increase the blood flow and all the lymph that is accumulating in your leg. About a week later, after wrapping her leg by a specialist, look at this foot now, the same foot without pain. It was a retired physician who recognized that this elderly woman wanted the independence, deserved the independence, and lo and behold, he helped. Thank heaven. Look at that. And it was all because of a simple wrapping. It was no surgery. It was the wrapping by a dedicated physical therapist who came to her rescue. That's just one little tiny story. And these are the kind of people that are going to help us in the future. And we can never, ever, ever underestimate the importance of one person. One physical therapist made all the difference for this woman. One retired surgeon made all the difference for this woman because we couldn't get the attention of anybody else. So this is what healthcare is going to be like in the future. We're going to have to make big changes. Let me give you one other example. And I don't want to paint a really bad picture for the healthcare system, but I'm going to do one right now, and I apologize ahead of time. This is a situation that did not occur in our tri-state area, rest assured. But another 74-year-old female friend, a retired banker, decided to have bilateral knee replacements. 74 years old. The orthopedic surgeon was relatively new. That is beside the point. The surgeon was also a retired Olympic skier. No, skater, not a skier. And we won't mention names, but you can probably put a couple things together. A week after her bilateral, and this is the bilateral knees, she was to have an x-ray made to make sure that the placement of the knees, the new knees, were in alignment. She was not helped off of the x-ray table. You probably know where I'm going with the story now. She fell, and she broke open both of her wounds that had not healed yet. They took her back to the operating room because they had to remove the implantable knees, and they put in some kind of artificial knee for her to heal. And while she was in the hospital, she developed some kind of infection within the wound site. They labeled it as MRSA. And they kept her in the hospital on heavy-duty antibiotics. She went home with home health aides to assist her with her antibiotics to be delivered in the home setting. It did not heal. She went back to the doctor. The doctor said, I think we're going to have to amputate your leg. It is not healing. This is after an elective bilateral knee replacement. She would not go for a second opinion. And the doctor who made the telephone call to her to say, we need to have an amputation occur here, said to her, and I can't make this up, I've never done an amputation, so I'll have one of my associates do that for you, who she had never met. We begged and begged and begged her to go for a second opinion, and she said, I have all the trust in my doctors. I said, why don't you even go to your primary care physician just to get another second opinion? No, I have all the faith in my doctors. 74 years old, retired banker. See those knees? They were all in alignment. And see today? She had her amputation about 2 weeks ago. And again, I painted a very negative picture of healthcare, and that's not the only side. Healthcare is very positive, but these are the kind of things that happen to those that age. And that's why we need to be on the forefront helping a lot of people. So let's turn to something very positive here. When we talk about old age, some of you may think 60 is an old age. What age do you think is old age? Elderly. Let's be positive. What age do you think it might be? 80? The closer you get to 60, probably the higher it goes up. Yeah, I can understand that. And to be called a senior citizen, you probably don't want to be called a senior citizen. You know what I tell the people that I work with when they talk about elderly and old? I said, no, they're just more experienced. So think about having a lot more experience along the way here. But sometimes people do feel old even when they're 50. We've already talked about that. But here is some new nomenclature that's out there, or it was at least new to me. Young old age, 60 to 70. Old age, closer to the 70. And the oldest old age, or the people with the most experience, are going to be those that are over 80. And we're going to see a few statistics in terms of how many people are actually living this long. I know you can't see all of this, but the most important point here is that there are 700 million people in the world, not the United States, of course, in the world that are over age 60. The more important statistic that I want you to look at here is that in 2050, which is not that far away, there are going to be 2 billion people over the age of 60, and that's going to outnumber the number of children. The question of the hour is, who's going to care for all of these people? Will there be enough caregivers? And we're going to see some revelations in terms of caregivers. Again, don't get confused with all of the statistics. And if you can't see it in the back, please move forward here. But this is from 1996, looking at 2025, the number of people who are in the age categories that you see on the left-hand side. The most important point to show you here is in 2025, which again is only 11 years away, folks. Look at how much older the world is becoming. Look at those top ranks. We don't see a lot of growth down here in the children, as I just said. It's all above, say, 50. Look at the difference in 1996 and the projection for 2025. Do you think that's because we're living healthier? Or is it because we're doing more interventions to help people live longer? Because I still see people smoking, I still see obesity, I still see lack of exercise, so I don't think we're getting healthier, but we're demanding more interventions to keep us alive. Whether it be open heart surgery, the knee replacements, the hip replacements, angioplasty, all of those kind of things, which is good because we are living longer, and hopefully we'll live a more productive life too. When we think about old, think about the entire country here, and look at China, the second one on the list there, compared to the United States. And this is for people age 75 and older. Would you have guessed China to be that, I'll call it healthy, it may not be healthy, but to have that kind of statistic. And heaven only knows what's happening in Spain. Look at Spain. Do they kill them off before they're 75? I don't know. Or do they not have the insurance? Do they not have the health care to keep them healthy? But there is something very different in Spain than there is in China. And that doesn't mean that the quality of life is any better. It simply says there are more of them in China, especially compared to the United States, which you think is very progressive, productive, and all of those kind of things. But keep China top of mind, because we're going to come back to see what things are happening in China and Japan. When we talk about the elderly, I think it's very important that as we talk about healthcare, it's also important to realize that it's not without a lot of health-related issues. As you can see, leading cause of death, heart disease, cancer, and pneumonia. You know what else is up there in terms of leading cause of death? What does the word abuse do to you? Crime. Suicide. And I bring up suicide on the heels of Robin Williams. And I wish that man could have died in peace and in solitude, but we all now know it was a suicide. But anyway, this is what leading cause of death. In fact, when we talk about the elderly, as we've mentioned before, we could have a real negative connotation. And some of these are the negative connotations that we're not going to go into depth with, but it's, are they incompetent? Are they not contributing to society? And that's one way of looking at it. But I want to encourage all of us to think in a more positive light. Because when we put a positive spin on the experienced individual, guess what happens? We look at elderly in a very different way. We look at elderly as being very important to society, being historians, being a contributing member, being a volunteer and offering services. And see how negative it could be and how positive it can be in the way we think. And if we think positive, just like we were trying to help the 95-year-old woman who had the leg pain, let's think positive. Let's get her back to functioning so that she can be a functioning member and drive to Biaggi's for lunch and sit at her favorite table. Those are the kind of things that are very, very important as we age. But again, it's the positive mindset. When we talk about mindset, and again, you can't see this, but there is an attitude survey out there called Kogan, K-O-G-A-N. It's been in existence since about the 1970s. And if you work with people who work with the elderly or the experienced, I encourage you to go and look at the Kogan's attitude test. And it really is saying to yourself, do we have the right kind of people with the right mindset taking care of our elderly clients? Do our clients have the right kind of people taking care of them? And this is real simple. It's on the internet, and I encourage you to go and just get a copy of it. Because the question that I want to ask you right now, we just talked about positive and negative attitudes. Here's the question. And I, meaning each one of you, don't value older people in our society as much as younger people. How would you truly answer that? Not what you think others want to hear. And you don't have to say it out loud. Keep it to yourself. But test yourself. Anybody want to share their thought with us? Brave enough to share it? Good for you. That's why you're here today? No, you're experienced, remember? Anybody else want to care to tell the group? Who's in long-term care here? Yes.
I would say I strongly disagree because I know that the vast majority of leading nurses are moving into an aging population. And our challenge is to recognize we're going to have to relook at how we're using our resource of elders, older adults, because they're a key piece of what goes on, and we've got to change how we're looking at it. I look at it as opportunities that people have so much wisdom to bring to the table, but we've got to be willing to slow down so that they can bring it to the table without feeling like they're not being listened to.
Or incompetent or whatever. Great. Okay. We're going to, yes.
I really disagree in that I myself am really, really old. Anyway, I value, aside from my dog, here, but my friends as far as discussing them. I feel strongly about discussing anything, any problems, emotional problems even, with the people around my age group because they've had the same experience. And I kind of find out, is this about the new for the course? You know, does this sound right?
This is part of aging? Yeah. Good, good. And it's good that we have a variety of opinions because we are all different. Let's bring it home. Let's bring it home another notch. I'm going to give you a test. And don't get any piece of paper out or anything like that. But we're going to do this together. What percentage of the U.S. population is currently over age 65? –
60%.
What's your answer? Wrong. It's 13%. With the average life expectancy at 77%. Okay, let's go to the next one. What percentage of those over 65 have at least one or more chronic illnesses? You say B? It is B. And that's one or more, and usually it's more. And you'll see some statistics there. How many caregivers are there currently in the United States? Anything you want. Could be a family member. It could be residential home. It could be anything. The answer is 50 million. But I want to point out this. We're going to need 80 million by the year 2020. Folks, that's 6 years away. Actually, 5.5. That's a huge jump. So who will take care of us? What percentage of persons with dementia live at home? $75 to 80%. You know the reason that many people are there? Financial reasons. That's all. So once again, let's look at it from a negative perspective and turn it into a positive perspective, because just like Robert Frost said, we have two roads we can go. Well, let's talk about some of the issues facing the elderly. This is not put up there to gross you out. It's to bring home that abuse happens. Even within the Deaconess Health System, a woman came in from an outlying hospital about 3 weeks ago to our facility and was admitted to the trauma ICU area. Non-communicative. She had been assaulted in her bed at home. Her family members found her. I mean, this happens right here in the tri-state. It's not something that happens in St. Louis, Chicago, New York City. It can happen right here. It's a health issue. Another health issue demonstrated by this picture is loneliness. And guess what happens with loneliness? It can lead to depression. And this is so common. And one of the reasons that it is so common is, look at this. And again, you can't see all of this, but this is percentage of persons who rarely spend time with friends. I want you to look at the United States right over here. And we classify ourselves as a nice, friendly atmosphere, nice, friendly community. But if you don't have friends, guess what happens as you age? And especially as some of your very dear friends pass on. We do not have that family structure. We do not have that friendship structure for people to check on each other. So that leads to even more loneliness, more depression, more alcoholism, all the things that you've just said. Another big health issue with the elderly, you know what this picture demonstrates? Poverty. Poverty. This is a woman who has no money, but guess what was very important to her? These are probably what she considers her friends. Let me feed my friends, the pigeons. Here's the incidence of poverty as we age. As we age, this is what's happening by classification. If you can see the green bar are the African Americans who are in poverty as defined by the United States government, who are 65 and older. Compare that to those children under age 18. And as healthcare becomes more expensive, even though there's going to be all this insurance and ACOs and all of that, the Medicare population is still stuck with a lot of expense, even though they carry a Medicare card and they don't have enough money to have a Medicare supplement and all those kind of things that go along with it. Another health issue faced by the elderly, represented by this, is dementia. And let's again put a positive spin on that, but it's a realistic kind of problem. Another one faced by the experienced person, and maybe it's hard to tell by this, but it's discrimination in the job setting. We have physicians come to us with a lot of experience, age 61, 62, and they say, will you still hire me? I'm so old. And I always correct them and say, no. Guess what I say? You have very much experience. That's exactly what we want. We can never discriminate against age. And in fact, sometimes as you read the business literature, the new retirement age is not 65. It's more like 67, 70, and that's acceptable. The things that some of the public traded companies have are policies, though, for mandatory retirement. And I think that those will have to be reevaluated at some point in time. So let's drill at home and talk a little bit more about this actual care for the elderly. This is where the elderly live. Again, you probably can't see everything, but the dark, dark navy blue is where the highest population of the elderly are living. Look at the Midwest. When you talk about North Dakota, South Dakota, Nebraska, Iowa, Texas, I think that population is so heavy there because that's a lot of farming community. They're holding on to their farms. They're not moving on. Because look at the coast. You don't find, and I should say something about Florida. Florida's going to fall off the edge of the earth. Any more people get down there. But anyway, that's where the elderly are amassing, and so you can pinpoint your own area. As we have already talked about the leading causes of death, add abuse to that, which is another big category. When we talk about abuse, let's also focus on crime does happen with the elderly. Whether it be violence, whether it be murder, rape and assault, it does happen. The other thing that comes up here is that there's a lot of financial scamming going on. I'm sure you've heard about this. How many people have received an email from Nigeria, send me $1,000 and you'll be guaranteed to get all this Libra, whatever it is. And yeah, and how many people have fallen for that? And usually when you read about it, it's somebody in their 80s and they thought someone needed $1,000 and let's do it. That's another form of crime in our book here. But let's look at some of the prices. We talked about the financial burden of being an elderly citizen. These are the kind of prices that are charged out there, and those that represent long-term care. We can appreciate all of the expense that you have in taking care of the elderly and making sure that they are safe and have the very, very best. But look at this, and think in your own mind, how many people can really afford this in today's economy? A nursing home can cost up to $400 a day. For those of you representing nursing homes, is that true here in the Midwest also? $400 a day. That equates to $12,000 a month. Take $12,000 a month times 12, that is $144,000 a year for 1 year of service. How many of us are saving $144,000 a year for our nursing home care? Probably not. Let's look at a private nursing home room. That's $14,000, let's up it to $15,000 a month. Not a year, a month. Take that times 12 and we're already up to about $160,000, $170,000 a year for a private room. In today's society, a lot of people want that privacy. They don't want to bunk up with somebody. Senior nursing home care, $26 an hour, and that is probably an underestimated amount. So it's still very expensive. 24-hour live-in care, if you can find that person that you can trust. And that's a big, big if. It's about $300 a day. A day. A day. And a lot of these people do not do it for a long period of time, and they call and they say, in the morning, I'm quitting. And it happens. It's just part of the situation. So again, who will care for these elderly people? And if you think assisted living is going to be the answer to everything, well, let me tell you, folks, assisted living is about $5,000 a month. And this is when you live in your own little area and you can go down and have group meals and those kind of things, van service to take you to and from. There is still a high cost to that, $5,000 a month. So 1 in 4 Americans are already helping to take care of their loved ones. And a lot of it is because of the financial burdens attached to that. As you can just well see, most of us are not saving these kind of dollars for the future of care. So I just want to divert a little bit of our attention to give you an idea of some of the cost involved in caring for the elderly, and it's really caring for the population as a whole. This is the healthcare spending of the gross domestic product. And you can see it's labeled for 2010. The United States is already close to 18%. As most of us in this room understand, that is not sustainable for the future. And this is why Obamacare, anything else about healthcare reform is getting national attention. Because the way we're delivering healthcare today, based on an illness model, based on paying you to do more procedures, is not sustainable for the future. That's a whole lot of percent of our gross domestic product, especially compared to the other developed countries there. This is also to tell you about the health care expenditure as we compare it to other countries. Look at the United States at the very top. That means that we're spending a whole lot per capita. And do you think we're getting better health care outcomes? If we were getting better health care outcomes, I think the economists could say it's all worth it. But we're not getting better health care outcomes. And again, that's a very big generalization without a lot of backing, so you can do your own assessment there. When we talk about premiums, look what's happening in the United States. A family plan is now costing about $16,000. How many families put aside $16,000 to pay for a health care premium only? A lot of the people we see now have health care insurance that has a $10,000 deductible. People in our community do not save $10,000 for a medical emergency. So even though they have insurance, they're written off as bad debt, charity, uncollectibles. And I'm telling you this side of the things because it impacts the family dynamics as to how we save to take care of the elderly. There is a connection here to the elderly, of course. This simply says that over time, 1970 to 2010, this is how the healthcare dollar has been spent. You can see that hospitals have decreased a bit. That's good. But guess what's increased? Nursing home and caregivers, near the bottom, excuse me, has increased from 6.8% to 9.7% over a short period of time. So more care is being delivered. And will those people be there? The hospital cost does represent 37% of the total. That's nothing to say goodbye to. It's not as big, I think, as what some people expect. This is the national health care expenditure. Again, it just shows that it's growing over time with a 4% annual inflation rate. And look at that. That is the year 2020 projected. And once again, it is not sustainable. Hospital costs per day, you can see that. Physician office visit, look at the United States. The United States is about $176 per physician office visit. And all of that is not collected. Brenda? And that is an attitude, and look at Canada's price. You probably don't see her. Again, we're making big generalizations here. But when we talk about that healthcare dollar and who's going to care for us, a lot of it is Medicaid, and a lot of it is Medicare. Don't underestimate the importance of Medicaid, which Governor Pence is trying to expand and is meeting some roadblocks there. Here's the annual per capita healthcare cost by age. Look at the United States. The United States is red. And are we living longer and doing better things? It's your own judgment there. This simply says the United States spends a whole lot of money compared to all those other countries, especially in taking care of people. As we think about aging and as we think about who's going to be out there to care for us, look at the people who are going to be demanded in long-term care. Are we going to have enough people out there to take care of us? It's a big question. Because as a resident of a nursing home, when we get ready for a nursing home, we're going to be probably in this 75 to 84 age category. And so when you combine that with 85 and over, that is 80% of all of the residents of nursing homes. Again, those people who are in long-term care, is that pretty much the typical age that you see? Just shake your head. Yes, yeah, you're right. Okay. Then we talk about the number of residents with Medicaid. We'll pass that up. These are the number of people that need assistance with ADLs. This is just to emphasize that people who need assistance, guess what number one is on their list? It's not eating, it's bathing. And in fact, this is why some people are bathing every other day or every third day. They don't have the assistance, and then that breeds all kinds of other situations. This looks at the number of chronic diseases. We've already talked about that. But look at the number of people who have 4 to 10 chronic diseases. It ranks as 26% of the entire population have 4 or more chronic diseases. And you know what happens? In a highly specialized world like the United States, they're probably seen by 4 to 10 different specialists. A little exaggeration there, but think about it. The pulmonologist, the surgeon, the podiatrist, the internist, the endocrinologist. Yeah. But that's the reality, folks. It's not just primary care. So who is going to take care of us in need? In the Netherlands, they have grocery stores set up, and this is all a pretend grocery store. It's to help people with dementia actually get encouraged to say, let me go out in the public. And this is how they are learning. But we have to be reassured there are caregivers out there. However, we're going to have to think differently. We're going to have to think very differently in the future, and I'm going to show you some things that may go, because some of you are not going to accept this as easy as others. Let me tell you what is hitting the market in terms of assistance with taking care of you as you age. Anybody care to guess what this is? It's a robot, and we're going to see some robots here. This is actually available in China and Japan, and they now can be programmed to assist you in being ambulatory and getting out of bed. Let's look at what else this robot can do. Here, this is a different robot that's actually in the home setting and can talk to you, can keep communicating with you, and can be programmed to do a variety of things that we'll see in just a second here. This is another robot that helps you with getting out of a chair, a robot that can do all kinds of things. This is a robot, believe it or not, that can assist you not only getting out of a chair, but helping you sit in a chair. The robot industry is going to get into the very technology-oriented fashion in terms of taking care of people. This is a robot that can help you eat. This is a robot that can help you walk. And look at this next picture. Help you actually walk upstairs. Think about those that are immobilized. This is here. This is available today. This is a robot that helps you wash your hair. This is a robot that will talk to you. This is a robot that it can be in your home, helping you take your blood pressure. You'll see the cuff down there on the side. This is a bed that's been designed that splits in half, that with the touch of a button, half of the bed becomes your electric wheelchair. Think about those that cannot get out of bed. Because we may not have the necessary number of caregivers for the future, these are the kind of assistive devices that are going to be required. Here's a robot that can pick up an object, retrieve an object, and get to the high shelf and pick things up. So these are the kind of people that are going to be depending on healthcare workers of the future. And I have to tell you this because there are not going to be enough physicians in the market, folks. This is a projected supply and demand. And if you look at the years there, it's not too far away that we are not going to have enough physicians. So what we're going to have to do is devise care advisors. This is the new term that is out there. The care advisor is going to coordinate your care from a primary care standpoint. And if you have multiple chronic conditions, you're going to come in for a super visit. You will visit with your physician for about 15 minutes twice a year. But you won't feel like that because your care coordinator is going to be assisting you with all the kind of things to get your care coordinated to keep you out of the hospital. And that's good. It'll be very similar to a case manager, but it doesn't necessarily have to be an RN, but it probably will be an RN or an LPN. And these are the people who are going to be depending on case advisors. And they will work alongside a physician. And they may not necessarily be employed by the physician. They could be employed by a variety of people. Because there are not enough people in the pipeline to be caregivers. And look at this. This says there will not be enough. And you can look at it in your notes later. There will not be enough people who will be interested in taking care of the elderly. That demand is there. Let me give you a picture of a certified nursing assistant and a home health aide. This is the current supply, and look how experienced, I almost caught myself there, look how experienced the majority of our healthcare workers who are now CNAs and HHAs. Look how many of them are females also. These people, when they retire, we don't have the pipeline to supplant their retirement. The CNAs, most of them have gotten into that role, and they're very, very good with the elderly. They got in there because they like to help others, and that is the reason to be a CNA. This happens to be Erica. Erica is currently a student at Ivy Tech Bloomington. And let me just read to you why she stays with healthcare. And I'm going to paraphrase this, but I think this is the kind of person that we need to take care of us. In the summer of 2012, I was part of something that had a large role in not only how I view the world around me, but also myself. For 3 months, I assisted in providing non-medical and end-of-life care for an elderly woman in my community. In those 3 short months, I learned many things about the woman in the position I was presented with. I learned how to communicate with someone who had very little verbal communication abilities, how to speak up for someone who was not capable of speaking, and it was simple as reading a recipe from a magazine, and it made all the difference. When I was approached for the job opportunity, I jumped at it. I met my patient when she was being fed her breakfast. She couldn't speak, but guess what she did? She smiled at me. Every day that I went to work, I was met with that big smile. As days passed, and after she moved to a hospice center, her daughter continued to employ me. She would tell me that her mother really enjoyed my company and would very much appreciate me being with her. The day that I found out she passed away, I was deeply saddened, but I remembered that smile that she presented every day. And I knew that this was not a sad day because I did everything I could to make her last days better. This experience truly changed my life, and I cannot wait to further my education and help more families like this. That's Erica. That's the kind of person we want. And the person that she wrote about was my mother. And the person that nurtured her was my sister. And this is Erica. And I hope that we have more and more Ericas in the world, because there are not that many out there. And Erica was very, very special. So let's finish this up. Home health aides, you see that most of them also want to help others. There's a special program at New York University. You can read about it. It's all about a group of nurses, physical therapists, pharmacists getting together to say, let's do a better job in taking care of the elderly. And that's what this program is all about. It is on their website. It's very, very encouraging to say there are people out there that want to do something very different to keep people out of the hospital. Because Medicare is probably not going to be around to do the kind of things that we see Medicare doing today. Think about the number of elderly and the number of people who are not replacing them in terms of being productive and adding to the Medicare rules. Too many expenditures, folks. Way too many expenditures. So here are some predictions for the future. This is where the elderly could be living. Look at this beautiful site. However, it comes with a big price tag. Look at this room. These are the kind of settings that we have in various communities that come at a very high price. They have a man cave. They have a bar room. They've got a cigar humidor. I mean, this is technology at its best. Okay, I'm going to move here. Look at what's happening. This is more technology that actually you can see moving. This is a person or a robot up here. See the Oreo cookie? That is here to stay. This is a robot that is actually in a house. Here is a robot bringing a man his cup of coffee because he supposedly could not move from his chair. If you look down here in the corner, you can see the robot actually doing a bathing procedure for a patient on a bed. This is part of the future. This is also a robot that talks to a patient, and this is the first time this patient had communicated in about 4 years, and she actually got to talk to her robot. Multi-generational housing, senior-friendly plans, co-housing, luxury living, home health, of course, all those kind of things are out there. So who's going to care for us? Will it be a robot? Will it be an aging CNA? Will it be an aging home health aide? Will it be a very expensive nursing home? It's going to be all of those, plus home health. It really is going to be all of us taking a new approach to taking care of the elderly, taking care of the experienced. And that's the message that I wanted to deliver to you today. So thank you very much. I don't know if we have time for a question or two, because again, I'm between the chocolate cake and that lemon cake. And I know where your heart is. So I hope you learned just a little bit of tidbit and got a little bit of stimulation there in terms of some new and different things happening out in the field. We've seen some cost on the robot. In fact, this isn't necessarily with the elderly, but we have three robots at Deaconess. We have a robot at the Women's Hospital, we have a robot in surgery, and we have a robot in our pharmacy department. It's the sign of the times. They do not call in sick. They do not get pregnant. Yeah, pretty good. So again, I hope you got a little tidbit. Yes? Pardon? More women are entering medical school, and now it's about 50% of the medical students are females. Here's the fallacy. We are graduating the same number of students, but again, this will be a sexist comment. The majority of the females do not want to work full-time for their entire careers, and that's okay. They want to take off and raise a family and all of those kind of things. So we may be graduating the same number of physicians, but not the same full-time equivalents. Yes?
I know you mentioned that the percentage of elders nationwide is 13%. Some of our counties in the tri-state area are already approaching 20%, especially our rural counties. How is our tri-state preparing for our aging population here in this region?
We are increasing the number of home health opportunities in terms of getting into more homes. We're also doing the care advisory role to keep people out of a hospital, keep them more independent. We will also have to do more education with family members because family members are going to be key to the future of keeping people independent. And there are only so many dollars to spend. Brenda.
This is just a comment. When I was working geriatric person, anyway, I felt like the combination of the young nurses and the older nurses were great. I felt the younger nurses could react faster in an emergency, but I felt like that I had a better judgment about conditions, whatever. I felt it was a good team.
It's going to take a lot of diversity, and diversity not only in gender and sex and all of that, it's also diversity in education and diversity in age. It all comes to the table as a team. Well, thank you very much, and I hope you got something out of it.